Hello, my name is Dr. Allison Romero. I'm a doctor of physical therapy and pelvic floor specialist, and I am here with the Anal Cancer Foundation for this conference to talk about taking care of you, pelvic floor physical therapy. Thank you so much to the Cancer Foundation for putting this on. What a great foundation you guys are. You have done so much to further treatment and research for people dealing with anal cancer. So thank you so much for what you do and for having me. And thank you to anyone listening for being here. I am so happy to be here with you, and I look forward to connecting more at the live Q&A. Okay, so let's get started. Disclosures, I don't have any. I have no conflicts of interest with this presentation. So what is pelvic floor physical therapy and why do we need it? I think a lot of you are either just getting started on this road with anal cancer and haven't quite started treatment yet, or maybe you're in the middle, or some of you have done the treatment and are on the other side. And so what we are looking at after what the anal cancer treatment methodologies are, radiation, most commonly radiation and chemotherapy. There's sometimes surgery. And so, but with any of these things, what we often are left with is all or some combination of these things: urinary dysfunction, bowel dysfunction, sexual dysfunction, and pelvic pain. And I can explain why on the next slide, and more specifically, what people are going to be experiencing and how improvable that all is. So we've got an anatomy review here, and we're going to look at the pelvic floor. On the left, we have the female pelvis, and you can see, let me see if you can see my mouse here. Here's the female pelvis, and we've got the external anal sphincter right here. On the male pelvis, we have the external anal sphincter right here. And the thing that's really different about the male and female pelvis, I'm sure I'm not telling you anything you don't already know, but on a female pelvis, the perineal muscle is open and there's a vagina. In men, the perineal muscle is fused and it terminates at the urethra with the penis. Females, we have a shorter urethra, no penis. So, but I show you all this to say how small this area is. So when we're getting radiation to the anus, we're only talking about maybe, 3 to 5 inches of space between that tissue and the rest of the pelvic floor tissue. So radiation is something that, they continue to improve their methods, but we, unfortunately, there's still kind of like pour over into the other tissues. And so when we're dealing with this, and when we're dealing with chemotherapy as well, and of course, surgery, we are dealing with thickening of the tissues, inflammatory responses of the tissues, injuries of the tissues, not just to the anus, but to the anus itself, the perineum, the vagina, the penis, the urethra, and any of the pelvic floor musculature, fascia, in the surrounding areas into the pelvic girdle, which we'll talk about more later. But so when I talk about urinary dysfunction, people are sometimes experiencing urinary frequency or pain with urination or difficulty initiating their stream, or it feels like they're peeing through a straw. We can talk about sexual dysfunction. There's pain with penetration. There's erectile dysfunction that can sometimes occur. When we talk about bowel dysfunction, we sometimes are looking at leaking of stool or gas, pain with bowel movements, really skinny bowel movements like pencils, constipation, or there's pelvic girdle pain that we're sometimes dealing with, like the hips feel really tight. You just don't feel like you have your normal range of motion or flexibility that you once had. And that is because of some of these treatment modalities that we've had to deal with. And so radiation is a burn to the tissue. And once we have it, it's sort of, in the biz, they sometimes call it the gift that keeps on giving. And that's because once we have radiated tissue, it's trying to sort of shore up all of its resources to not allow any more damage. And so it sort of like thickens all the tissue. It thickens the fascia, the collagen starts to change. And we will sometimes see a narrowing of the canals, which is a stenosis, which is where we would talk about like dilators and fascial lengthening. And we're going to talk about that down the road. When we're doing chemotherapy, we've got just chemicals coming through our systemically, our whole body, and it often will go to the site of injury. And so a lot of times, even though chemotherapy is not specific to the anus, when we're pairing that with radiation, the chemicals from the chemotherapy are often going to that area and sort of causing more of this like toxic soup, we call it, or like inflammatory kind of junk that needs to then move out so that those muscles can function properly. And of course, if there's been a surgery, we are cutting a tissue, and a lot of times we're cutting around that sphincter, either the external or internal sphincter or both, and then we're limiting the function there too. So these are all things that we can rehab, and I hope we all do. I think it should be a part of just sort of like the protocol after we go through the treatment. There should be a little rehab appointment so that we can make sure everything is working as well as it can. Okay, so I'm going to put it here first, how to find a pelvic PT. There's two great websites here, directories. There's pelvicrehab.com and pelvicpain.org. During this COVID time, a lot of PTs have gone virtual as well. So if there's someone that you follow on Instagram, or you find someone on one of these websites that really speaks to you, some people are doing virtual appointments as well, myself included. So it's a great tool to be able to talk face-to-face with somebody and just kind of talk over some things, and get a plan if there isn't someone specifically in your area that you can see in person. But these are great resources to check out. So exercises that we can do at any stage, wherever you are, if you have not started treatment, if you are in the middle of treatment, or if you have finished treatment, if it's been 20 years since your last treatment, anywhere you are in the process of this, these are 3 things that you can do that can help you improve, that can make you feel better. So number 1, simple as it is, breath work. 2 minutes a day, often 5 to 7 days a week. And what we're looking for here is to inhale and fill up the belly, descend the diaphragm, descend the pelvic floor. So we're looking to lengthen and release on the inhale. And then exhale, we're going to allow things to recoil and engage. So on the inhale, we're breathing in through the nose, filling up our belly, filling up our lungs, expanding 360 around the rib cage. And then we're going to exhale. And I often exhale like I'm fogging up a mirror, or I'll make another noise like shh, to increase the engagement of my pelvic floor. My pelvic floor is going to lift. My deep core is going to engage. My belly button is going to pull back towards my spine. And that is something that we can do as much as you want. I am saying 2 minutes a day, 5 to 7 days a week. But you could do it 2 minutes, at a time, 5 times a day if you really wanted to, if the breath work was something that you could really call on. But this is great to just stretch the tissue, just beginning stretches. It's great to engage the muscles. And it's also great for calming and stress and anxiety. And this is something that you could absolutely pair with like a mantra or something that you say to yourself. 2 great ones are I am safe or I am healing. The pelvic floor is really important to our like survival feeling. So the vagus nerve terminates in the pelvic floor. In yoga, it's called the root chakra. And if that area is under stress or under, treatment for anal cancer, a lot of times we just have this feeling like we're not safe. So telling yourself that you are safe is a great thing to do, especially pairing that with the breathing. So muscular fascial lengthening, this is another thing that you could do 2 minutes a day, 5 to 7 days a week. Some of it is just positional. So you can bring your knees above your hips, and that's going to stretch the fascia that spans from your low back to your knees, basically. And we don't get a ton of that because we sit in chairs so often. So we're kind of stopping ourselves at 90 degrees. But, in human history, we were not sitting in chairs, we were squatting. So we're looking for knees to chest. We're looking for child's pose. We're looking for a deep squat. And with a deep squat, a lot of times you're hanging onto like a counter or a bedpost or doorknobs to allow yourself to be in that deep squat, because it's for a stretch. It is not for like muscle strengthening to be there. Dilators I'm including in this for fascial lengthening. These are something that this is the one thing that not everyone is going to be doing. These are going to be done when you need to. And your physician can tell you about this. A PT can tell you about this. But this is going to be for people that were having stenosis concerns. So in the vagina or in the anus, and we want to maintain that patency of the canals, we're going to want to use dilators there. And those are something that in the beginning, like the first 2 months or so, you'll want to do every day for 2 to 10 minutes, something like that. And this is something we could go over more specifically in the Q&A, or something that you could talk over more specifically with your provider with that. And I think I didn't say this already, the muscle fascial lengthening stuff can be paired with the breath work. So you could combine those and just do them all as one for 2 minutes a day, 5 to 7 days a week. Or you can separate them, whatever feels better to you. And then pelvic floor muscle activation. So we're not looking for like a ton of strengthening, because that's something that more specifically you'd want to talk to a PT about, to make sure that we're not feeding something that's already tight. But activating is always okay to do. And we know that in injury, the brain sort of like mutes out or smudges some areas of places that have been injured or ailing for some time. And so this is a way to sort of turn the lights on and bring the pelvic floor into the equation. And this is going to help with, I mean, you name it, but definitely any incontinence. So any urinary, bowel, gas leakage, this is going to help to kind of give it some wherewithal. So I recommend just 10 activations a day, 5 to 7 times a week to start. And this is something that you could build upon, again, with like a PT on your specific plan. But you want to think of closing all of the holes. And I think of it from back to front. So tailbone to pubic bone, I'm closing my anal sphincter, I'm closing my anus, I'm closing my vagina, I'm closing the urethra. So for women, you're thinking closing the anus, closing the vagina. You can even think on the vagina, like picking up a blueberry or like picking something up, closing the urethra, stopping pee. Men are going to think closing the anus, lifting the penis, stopping pee. And those are the ways that we can engage that pelvic floor in a healthy way. You want to pair it on the exhale so that it's getting that natural recoil. So I like to do, like I said, like fogging up a mirror or saying shh. So I'm going to close the holes, engage from back to front. You can also think of engaging front to back, so pubic bone to tailbone. I'm not tilting my pelvis here. I'm just thinking about the muscles in between the pubic bone and the tailbone. I can think about squeezing my sides in towards midline, or I can think about going around in a circle. So I call this a quadrant circle. You can go from pubic bone to right sits bone, activate that quadrant. Right sits bone to tailbone, activate that quadrant. Left sits bone to tailbone, activate that quadrant, and then pubic bone to left sits bone, you activate there, and then reverse the order, and you're going to go around the other way. So these are 3 groups of things that you can do on an almost daily basis, and it will only help. So I'm going to come to the next slide. Thank you so much for being here. It was an honor to have a chance to participate with the Anal Cancer Foundation. I'm so grateful to be a part of you and your time, and I look forward to answering all of your questions in the live Q&A when we're together. Okay, take care.